thank you very much for the opportunity to present on what I feel is a very important topic to try and prevent the morbidity and mortality of colorectal cancer, namely screening. As Rana already alluded to, the colorectal cancer screening program so far in the Netherlands has been very successful, and I'm very fortunate to be a part of that program. And often we get asked the question why our program is so successful, since we are achieving participation rates that exceed 70%, which is among the top in the world. And often one of the reasons that's been proposed by people who ask the question is that's because we're from the Netherlands. And if you look at participation rates in the countries around us, like Flanders in Belgium or France, you can clearly see that there's a gradient going from the Netherlands to France. And so maybe there is a gradient going from Northern Europe to Southern Europe. But then if you look more closely at the data, and we take the example of Basque Country in Spain, then we see that it's quite different. So while we get accused often that it's the Dutch culture that is causing this very high participation with screening, I think there's more to it. Because if you look at Basque Country in Spain, and for example, Basque Département in France, you see that there's a huge difference in participation in the screening program, while of course, culturally, these groups are not that different. So I don't think that culture is the main explanation for the differences in participation and access to screening we see across Europe. So let me dive into the evidence from the literature on how you can actually achieve high participation. Well, one of the first things to consider is using the fecal immunochemical test. Several studies have evaluated and compared different types of screenings in their programs. And I'm using the example of the Netherlands here because I'm most familiar with it. But before we started implementing our national colorectal cancer screening program, we actually performed 3 large pilot studies in different regions in the country, and we compared participation rate and yield of these different tests. And we saw something very striking. In the Netherlands, if you look at, for example, the stool-based test, which are the 2 left columns, the participation rate was substantially higher than, for example, for the more invasive tests, sigmoidoscopy, colonoscopy, and CTC. And you see that if you take the best stool-based test, the fecal immunochemical test, in this pilot study, we already achieved 60% participation, whereas for colonoscopy, which is often considered the best test, we only got 22% participation. So although colonoscopy may be more sensitive to detect cancer and precursor disease, because of the high difference in participation, already after 1 round, there was not so much difference in the yield of FIT versus the yield of colonoscopy. And already after 2 rounds of FIT, we actually had a higher yield with FIT than we had with colonoscopy, clearly illustrating that the choice of test is an important determinant of participation. And we were not the only ones to show that. This is an example from a different country where you can also see that if you only offer the population sigmoidoscopy, then the participation by age is lowest. However, if you offer them FIT, then you see that with 3 rounds of FIT screening, the participation rate is substantially higher than with sigmoidoscopy screening. And as a result, you can see that actually the yield of 3 rounds of FIT screening is comparable and even higher for cancer than the yield for sigmoidoscopy. So although sigmoidoscopy may be a better test, actually you get much more if you do a test that people perform more often. And it's not just that you only, if you want, then there is also a room for colonoscopy, but you could also offer people the choice, because not everybody is up for colonoscopy. And that's what this study shows. Here they randomized individuals to either only colonoscopy or colonoscopy, and if people did not participate, they would offer FIT, or you would offer people the choice between colonoscopy and FIT. And what you see is that if you only offer people colonoscopy, then you have 17.5% participation. This was in Poland. Whereas if you offer the choice, or if you offer FIT after colonoscopy, then eventually your participation will be almost 10% higher, and your yield will actually potentially increase, because this was just one round of FIT. But if you would offer multiple rounds of FIT, this yield of the program would increase. So one thing that you can do to achieve a high participation rate is carefully consider your choice of test, or at least in your choice of test, also include the fecal immunochemical test. The second action that you can take is to do an active invitation or a mailed outreach to your population. This is a study from the United States by Selby and colleagues in the Kaiser Permanente program. And what they have there is they normally did not have an outreach program. So without that outreach program, approximately 40% of their population was up to date with screening, either due to a previous colonoscopy or due to a previous sigmoidoscopy. When they send out FITs to the 60% of the population that was not up to date with screening, then actually they would be able to increase participation by another 20%. So going from 40% participation to 60% participation with screening. And they have some other measures in place where they get their uptake even higher. But you can clearly see that actively approaching the population for screening will definitely increase your participation with screening. The third thing that we can all do to improve participation is that if you do the FIT screening like we propose, that you include the FIT in the invitation. There has been a quite recent systematic review by Rott et al. In the European Journal of Cancer Prevention, and that included 6 studies. And I found a 7th study that also did a similar thing, where they performed randomized controlled trials, and in which one arm received an invitation for screening, but the test needed to be collected at a pharmacy or a GP. And in the other arm, they send out an invitation including the test kit. So there was no need to go and collect the kit. And you see that every single study that was included shows that including the FIT kit with your invitation substantially improves your participation. And the differences is higher for some settings than other settings, because there are differences where it almost doubles, and then there's differences where it's maybe more modest, but everywhere it's clearly showing that this works. The fourth thing that we also know from literature is that it's good to send a reminder letter. So this is 3 studies included in that same review by Rott et al., where we show that if you send a reminder letter to people that haven't participated yet, that your participation with screening, your overall participation with screening, is going to be higher than when you don't send a reminder letter. And again, there is quite a difference in how big that effect is, but generally you see that in all 3 studies, this does have a significant effect. The 5th thing what we can do is we send an advance notification. It has been proven, again, from 3 different studies in that same review, that if you, prior to sending the actual invitation for screening, send a notification letter where you sort of warm people up for the screening, let them know that this is coming, and so they can psychologically prepare for it, that this has a positive influence on the screening participation. And again, all 3 studies consistently and significantly show that this works. And finally, involvement of the GP. And it's very important to be clear about what we mean with involvement of the GP. Because, as I said, if you involve the GP to get and collect the test there, that's not going to work. But if you involve the GP, for example, by sending the invitation for screening on GP letterhead, or by including GPs when people have not participated and asking them to remind their patients to participate in screening, or to send a reminder to the GP, or giving them a training focused on colorectal cancer screening, you can really see that this makes a difference in participation. Again, 3 studies consistently showing that participation with GP involvement, but not collecting the test there, is higher than participation without GP involvement. So the evidence is clear. It's not just cultural differences that define the differences that we see in participation in screening across Europe. There is clear evidence that there is several measures that you can take to improve participation in your country. Include the fit as one of the screening options, send out active invitation, include the test with that invitation, send reminders, send advance notification, and involve the GP. But the problem with that is how to implement this practically. And the best way to do this, I realize when I talk to people across Europe that they have questions, but how do you organize this in the Netherlands? And how do you organize that in the Netherlands? So the best way is to try and learn from each other's experiences. And that's why I like these webinars that DICE organizes so much. And based on webinars similar to this, I've been approached by people, so how do you do this in the Netherlands? And so sharing those experiences has led us to have several practical workshops defining, okay, but how does it work with legislation? How does it work with the health insurance companies? And so that we can really dedicate time and experience and exchange experience with each other. And we think it's necessary to do this more structurally. And one of the ways we've been trying to do this has been as part of the Utopia project towards optimal screening in all of Europe is what it stands for. And the objectives of Utopia were to systematically evaluate and quantify the harms and benefits of running programs for breast, cervical, and colorectal cancer in all European countries and try and identify ways to improve the health outcomes and equity. But more importantly, the aim was to provide national, regional, and local policymakers with expertise and tools to evaluate and quantify their own cancer screening programs and by learning from each other's experience. And this program had been running from 2015, and unfortunately funding ended in 2020. But the good news is that we have been refunded for a follow-up project called Utopia East, which will start in 2021, May 2021. Which will focus on Eastern European countries, but is also open to other European countries. And again, we want to organize interactive workshops for the participants so that they can build capacity for self-evaluation, but also exchange experiences and learn from how other countries have implemented stuff and to continue to have this dialogue to try and improve cancer screening programs across all of Europe. And with that, I want to thank you for your attention, and I'm happy to take any questions later. I think there's a dedicated session for that. Thank you so much.